So our maxillary antrum, uh, it is sinus, right? And it is the largest of the pronasal sinuses. Its volume is on average 10, 12 centimeter, cubic centimeters. Not sure how system do you use in United Kingdom. Not metric or metric, just like I think that it's not going to be a problem for you to switch to another systems. So it's about 10, 12 cubic centimeters. So, but it's varying from 3 to 30. Of course, it's very, very individual, right? So depending on the degree of pneumatic and sclerotic types of the maxillary sinus are distinguished. Of course, it's very individual. And the sinus is divided into upper, inner, anterolateral, and posterolateral, and lower walls. It's just anatomy, right? So the upper wall is the thinnest, especially in the posterior part. Often in the lower wall of the infraorbital canal, there's areas devoid of bone tissue 2 to 4 millimeters long. And here you can see the paranasal sinuses. So we have frontal sinuses. It's green ones, right? Cell of the ethmoid labyrinth. It's a purple ones, and sphenoid sinus, and the maxillary sinus that we talk today. It's a blue one. Let's move on. So features of the location of the tips of the roots of the teeth of the upper jaw, too much off here, in relation to the maxillary sinus. That is a problem. In dentistry, that is a problem because we always struggle with that because our teeth very often are two upper um, root of upper teeth, right? The root of upper teeth, it's very often located located in that maxillary antrum. So we talk about upper premolars and molars, and the floor of the maxillary antrum are closely related and share a common innervation. As a result, dental symptoms and antral symptoms can mimic each other. That's why we are working with otolaryngologists, right? Dental procedures may be complicated by problems involving the antrum, including creation of an oroantral communication, displacement of a foreign body into the antrum, and fracture of the maxillary tuberosity. Antral pathology may be incidentally demonstrated on the dental radiographs, but that is a problem because when you have, for example, orthodontography like this one, it's just two-dimension picture, right, of three-dimension space. So we could be, how to say that in English, maybe we could be deluded by how our roots located, right? Are you still here, Kennedy?
Yeah, yeah.
Okay, so maybe you know what is that, and if you're working already, or you're not working as an assistant, or I thought
I'm not
that
working.
you're not working.
No.
Okay, so that is orthodontography, and here you can see the lines. Can you see my mouse cursor or not?
Yeah, yeah, okay.
Yeah, so here you see the line of lowest. wall of our maxillary antrum, and it's very visual that the roots is like inside that antrum, but it is not. Because, as I said, it's just two-dimension picture. If you want to be sure of 100%, you have to do a three-dimension procedure like computer tomography to make sure that your roots are not in that antrum. And I suppose you know that guy, right? And the point is things are not always that they seem, right? So here you can see that problem when you moving that two-dimension picture, you understand that that's not the reality. Okay, so if you want to make some decision about extracting or tooth extraction and problems that you could have during that tooth extraction, please do three-dimension X-ray or three-dimension tomography. It's very important. Okay, so it's more about oral otolaryngologist part, but it's they call that osteonatal complex, the main anatomical and functional unit of the nasal cavity, but that's not our problem. That's their problem. Okay. So when we talk about antrum maxillary sinus, we have to understand that it is connected with nasal cavity. With nasal cavity means here. So here you see a schematic representation of the maxillary sinus here. In this picture, in left picture, yeah, you see the normal state of mucus of the maxillary antrum. See, there is a way here, and with that way they connected means our nasal cavity and maxillary sinus. So they're connected. And when you have not you when patient have sorry, when patient has a problem with his mucous membrane, it is not in good state. I mean, mucous membrane. So it starts to enlarge, right? Because it's inflammation, it's infection, of course. So that way it's closing, and all that liquid, it just starting to collect there. And of course, there's not septic conditions. So it starts to become a problem because it developed into a pus. So that's why it's very important to find a right solution just before you have a problem. And that's why we need to understand that we have very specific cells there. Yeah, maybe you remember that from the histology course. The mucous membrane of the maxillary sinuses covers the bone walls and consists of three layers. The inner epithelial layer, represented mainly by ciliated, cylindrical, and occasionally mucous goblet cells. Hope I pronounced that well. The middle layer, which includes acinar mucous glands located in the stroma, and the other layer, which is dense connective tissue adjacent to the bone. Oof. Okay, so why we have to understand that? We understand that cylindrical ciliated cells. They just have those thin parts, like, and they just evacuate all that problem. Okay, so you remember that. So that's why all the product of those cells that inside sinus, it evacuates normally. But when we have a problem, like disease, like some, when that way, that connected sinus and nasal cavity closing, we have a problem with nasal and with maxillary sinus. Whew, I hope you understand something what I'm trying to say, okay?
Yeah, yeah.
Or not?
No, no,
Okay.
your English is very good. You're hard on yourself.
Okay, thanks. So, the diagnosis that we have is called acute sinusitis. Of course, there is a chronic sinusitis too, but we start from acute sinusitis. So, this sinusitis may affect any of the paranasal sinuses, but is usually confined at any one time to a single sinus. And here we talk again about maxillary sinus. It's our main sinus in dentistry. It means. Um, it is a bacterial infection and typically occurs after a viral upper respiratory tract infection. And we have very typical guys here. It's Haemophilus, Pneumococcus, Streptococcus, Staphylococcus species, and anaerobes are commonly found, as they always found, like, because we have very, very typical infection here. So we have all those species like normally, okay? And when we have problem with our immunity, we start to have a problem with them too. So we have maxillary sinuses. Sinusitis is usually related to impaired antral drainage with maybe caused, which may be caused by. And here we have two ways, right? So first one is mechanical obstruction of the ostium resulting from, and few options. Inflammatory edema of the nasal mucosa due to a common cold, yes, or you call that flu maybe. And also we could have ethmoid polyps, or we could have deviated nasal septum. It means like it is not straight, right? Impaired mucus clearance resulting from poor ciliary action. It's those cells that we noticed before. So when they were not good, right? Mucosal damage caused by chronic infection of surgical stripping, or the viral damage caused by a common cold, or occasionally due to rare conditions such as a primary ciliary dyskinesia, so where those cells not work well. Abnormally thick or sticky mucus, as found in cystic fibrosis. Accumulated secretion become infected, allowing a collection of pus to develop in the antrum, as I tried to describe before, right? So symptoms of acute sinusitis usually appear in a few days after the acute cold symptoms have resolved. Pain, headache, nasal obstruction, a purulent nasal secretion, and post-nasal drip, a discharge of mucus into the pharynx, are commonly found, and there may also be fever and malaise. The pain is dull, heavy, throbbing, and located over the cheek, and in the upper teeth. It may resemble toothache, but is not related to hot, cold, or sweet stimuli, although it may be increased by biting. Typically, all of the posterior teeth of the affected side are painful and tender to percussion, although no obvious dental cause can be found. So, clinical sign of sinusitis, very shortly, right? Sign of written upper respiratory tract infection, like rhinorrhea and nasal redness, dryness or crusting, tenderness of the cheek, especially in the infraorbital region and canine fossa, tenderness of teeth in whole buccal segment to percussion or pressure, tenderness of the anterior antral wall, intraorally swelling and inflammation of there's a problem here, right? So swelling and inflammation of the cheek, rare in sinusitis. Um, what we have to understand before tooth extraction, according to that antrum. The following complication may occur during the extraction of posterior maxillary teeth because of the close proximity to the maxillary antrum. We could have as a bad result could be creation of an oroantral communication. That's a huge problem, and displacement of it to root into the antrum. That is huge problem. And fracture of the maxillary tuberosity is less huge, but still problem. So that's why we need to understand what we doing and where are we working. So a main area where we're working. Maxillary premolars. Oops, my notebook is dying. Okay, hope it's not gonna die. 3 minutes. Okay, maxillary premolars and permanent molars are most frequently implicated, although permanent canines may occasionally be very close to the antrum. Complications may also occur during the surgical removal of impacted, partially erupted, or unerupted teeth, like canines, premolars, and the third molars. The extraction of deciduous teeth does not present a risk due to their relatively small size of the antrum in the children and the presence of the developing permanent teeth. So here we have oroantral communication. You can see how it could be, how it looks like. Okay, so just how it looks. An oroantral communication is an abnormal connection. It's very bad thing, right? So that's why it's abnormal connection between the oral and antral cavities. An oral antral fistula is an epithelialized oral communication. It's just abbreviation, right? Although the term and communication and fistula are often used interchangeably. The creation of that communication most commonly follows the extraction of the maxillary tooth close related to the antral floor, typically the first molar, which lies close to the lowest point of antral floor, although the premolar or molar might be affected. That communication and also form as a result of an alveolar fracture running through the antral floor wall or be due the direct trauma from a bow or chisel. Left untreated, and that communication may heal spontaneously or persist as and fistula means oroantral fistula. And of course, there is a lot of ways how you can treat that. There is a few surgical procedures that could close that connection. You can use any of them, or you can create your own maybe. But of course, there's just two ways. Means this one. So you can take the mucose from um, palatine, right? Palatal rotting flap it calls, and take tissues from buccal side. So all those everything that exists is based on those two ways. So, of course, you can invent your own technique to close that connection, but everything is already created. And about pharmacological treatment. So, of course, it should be antibiotics, it should be nasal drops. Maybe if it needs, it could be anti-inflammation drugs and of course analgesics. So nothing special. Here's everything is very, very comprehensible.